Hi guys, this is Dr. Barani again. I'm a vitreoretinal specialist. I'm an ophthalmologist working at the American Eye Retina Center in Erbil, Iraq. So we wanted to talk about today a new topic that I thought about. I've been discussing with my colleagues about what important things you want me to discuss. And one of the things that came up is the one-day pre-phaco surgery preparations. I mean, what people who, most experienced surgeons probably don't do that, but most people starting to do phaco surgery, they're interested in learning what you should be doing the day prior to the surgery. So one of the important things I think you should be doing is to read about the phaco techniques. So you want to reinforce your knowledge, such as maybe you're learning how to do a chop technique or you're doing divide and conquer technique, then you probably need to read about those techniques. So I personally recommend that all beginner surgeons should learn how to do phaco surgery by using the divide and conquer technique. This is the best technique ever. So it is important for you to learn how to do divide and conquer before you go to more complicated techniques such as stop and chop, and all the rest of techniques that you see on YouTube channel. I feel divide and conquer is a very safe technique. I think most US residents, when they learn phaco emulsification, they learn the divide and conquer technique, and that's actually the best technique out there. After many thousands of surgeries, I still use divide and conquer in pretty much all my surgeries, except for some brunescent cataracts that I use the chop technique or stop and chop. So it is extremely important to kind of review your knowledge, the facts and the knowledge about these techniques before you do. Okay. So the second thing I thought you should be doing is to see as many videos as possible. Number one, I think you should be seeing your own videos, because I was kind of crazy about watching my own videos, watching how I do the capsulotomy, watching how I do the paracentesis incision, how I do my keratome incision, and I kind of check, okay, I did this kind of incision today, and then it didn't leak at the end of the case, so maybe I should replicate what I'm doing correctly. Okay, I did this paracentesis incision and now it's leaking at the end of the case, so maybe I should change my technique. So watching other people's video is important on YouTube, but what's more important is watching your own videos. So if you are a beginner surgeon, it is really important to have a video recording camera in your operating system. I think that's a very essential point for your learning, and I think when you start reviewing your cases, watching your videos, the learning curve just goes up right there. It is very important to kind of make a mental note, also, or even a paper note of the mental, the mistakes, the mishaps, the misfalls that happen during prior surgeries. That is very important, so you kind of tweak your technique the next operation you go in. So for instance, keratome incision, you start going and you probably do a 1-step, 2-step, and then 3-step, and you see the results, and you see even up until recently, when I was getting some kind of corneal astigmatism post-operatively, and I noticed, and actually one of my colleagues kind of gave me a hint about that. He said, Dr. Barani, I think your keratome incision is a little bit too anterior. So what I did, I start, going more posterior, kind of limbal based incision, and I found that my post-op astigmatism is much less than prior, and the patient weren't complaining about the residual astigmatism. So that's very important. I mean, you also should discuss with your colleagues, with your friends who are in residency with you also. And also another thing that a note I made is to go over the surgery mentally. I mean, that is an extremely important point. What I do prior to surgery, and even till now when I have a complicated surgery that, I haven't done a lot of it, I usually kind of close my eyes and just kind of go over the whole thing, washing the eye before starting paracentesis, incision, then putting the viscoelastic, the capsulotomy, and then the viscodissection, the hydrodissection of the lens, rotation of the lens, dividing and conquering the lens, taking each piece out, and then so on and so forth. But that is really important because that's when you kind of, I think, it sticks in much better, and then it allows your subconscious to work and you're not realizing it. So that is very important, and I do that prior to surgery also. Anything that I'm not comfortable with, I'm not confident with, I usually do that. So mental exercise, mental preparation is just as important as reading. I think it's more important than just reading about it. Also, if you have access to wet lab, I think access to a wet lab is extremely important. I used to do that. I used to do the capsulotomies on a pig's eye. Actually, the residency program helped us do that, but some residency programs, they have the virtual, I don't know the name of it, but they have the virtual lab where you can do capsulotomies, and I remember that capsulotomies really simulated the actual surgery a lot. And you can also do it, you get a Utrata and use it on a piece of tomato and do your capsulotomies. So all these things, even suturing technique, you may want to do that also. Just get a chicken, slice a chicken, and try to suture it. So the real life we talked about, the virtual wet lab, and also one important thing to do, not the day before the surgery in the clinic, because usually you plan or you schedule next day kind of phaco, is to go over the IOL master. It's really important, and to choose your lens carefully. You have to make sure the axial lengths are close between the right and the left eye, except there is big high ensimetropia. Again, you want to check the K readings. Some patients I just had yesterday, and I did the surgery today. I mean, yesterday I was, probably going back and forth between me and the technician, trying to figure out the correct K reading for that patient. So I think the first IOL master was incorrect, the second one was incorrect, until the third one that I think I got the right reading. The patient had keratoconus, had high ensimetropia, hyperopia, and that's why it is important also when you have such anomalies is to go ahead and order in Pentacam. And I chose the K readings from the Pentacam. I put it in the IOL master. I checked the axial length, and then I finally got the correct power for the patient. Also, I mean, and for that matter, when you're still unsure of your IOL master, you probably want to use or operate on the non-dominant eye first to get a clear idea of where you're at, +1, -1, 0.5 from your target, and then and then you make a decision for the dominant eye, and you probably be more precise that way. What else? Yeah, I think that's pretty much it for today. Also, one last thing: if the patient has astigmatism and things like that, you may want to consider doing an LRI or considering discussing toric IOLs with the patient. because that is extremely important to make your patient happy. So again, these are my opinions, guys. These are only my opinions, and this may not work for everybody. So this is just little things that I wanted to share and talk to you about, so you kind of have a clue. And then again, I want you to let me know what kind of information you want me to discuss, and I'm happy to do so. I'll give you my, give you my kind of pearls that I've got over 10,000 surgeries that I've done so far, maybe 12,000 surgeries now. But so I can, discuss things with you. I'll post this on Instagram, I'll post this on my YouTube channel, and post it on my Snapchat. Okay, so please do subscribe, like, and share, and thank you very much for following me. Thanks a lot.